I'm Jaquelini Barboza. I am a dermatologist. I live in the south of Brazil, here. And if you put a magnifier here, you will see this little red point. This is Santa Cruz do Sul. This is my city. That is, we have the 30th Oktoberfest, biggest Oktoberfest in the world. We have our immigrants from Germany in 1890. So we are love chop and beer and party. This is my conflicts. So I will bring a case of a man, 37 years, that have psoriasis since 2012. He had a severe disease with nail psoriasis, and he had already treated with phototherapy and acetylcholine with no response. When I asked him if he had joint pain or had eyes, he said, yes, I already had this. So this was 2012. I asked some exams, and in my clinical exam, my patient had PASI 22, BSA 26%, and the LQI 24. So I started methotrexate, 15 milligrams a week. Some months later, he returned with little response of methotrexate in the skin. His PASI was 15. But the joint was asymptomatic. So I raised the methotrexate for 25 milligrams a week. Okay, some months later, he came to my clinic again and said, I am sad. My life is bad. My skin is not good enough, but my joints are okay. So, okay, his LQI was 28, sorry, and okay, he failed to methotrexate. At this point in Brazil, that was 2017, we don't have access to biological treatment for psoriasis, even in the public or in private health insurance. But we have access for patients who had arthritis, psoriatic arthritis. So I started using ustekinumab for my patient. Just most weeks, and he reached PASI 100, joints asymptomatic, but he said to me that he gained weight, but his LQI was the 17. So why? I think that this occurs because the patient that had psoriasis for several years and with a huge impact of his life, they need more time with the skin clear to be safe and really feel safe about his quality of life. And I think that is like an emotional scar, this the LQI. I see this a lot in my patients. So, in 2008, 1 year later, he was with PASI 100, but started CrossFit and initiated with joint pain in knees and wrists. CrossFit is like is an exercise with a lot of it's a lot of Obrigado. Impact. It's a lot of impact in the joints. So I asked to him to change your exercise, your type of exercise, and I asked some exams, but blood and joint ultrasound that I have in my city. But this is a real case. This is a real life. My patients run away. After 22 months, he returns, complaining that he is with his skin bad, with PASI 80. He stopped using ustekinumab for 6 months, in the last 6 months, because he didn't came to the appointment to receive the paper, this prescription, to take to the insurance. So he had, in this time, he was with no treatment, and with psoriasis and joint back pain and lactitis. I asked some exams, and in this time he did. And CRP was 96, the PPD was 0, X-ray normal, and MRI with sacroiliacs. So I need to talk with a rheumatologist. And I asked she, can I use guselkumab? And she asked me, this is 19, okay? No, we don't have a lot of information about guselkumab in the axial disease, so I think that this is no the best choice today to these patients. So we started adalimumab in 19. So he reached PASI 90, and the ALIQI 18. But he said to me, okay, I am not good enough, so I initiate methotrexate 15 milligrams a week, plus adalimumab. And he asked me, I am not happy. I need to start phototherapy. Could I? Oh, yes, you could. So my patient, after start guselkumab, he stayed a little time in phototherapy, and methotrexate, I just take her out. Until 28 August 2021, today, my patient is on PASI 100 with his psoriatic arthritis controlled. So he's happy, and I'm happy, and his wife is happy, so everybody is happy. Are happy. As most psoriatic patients are under our care when they start psoriatic arthritis, what is important for me as a dermatologist to know about PSA? So when I see this figure, we see that the same inflammation that makes psoriasis make a lot of other disease. So we need to think in that when we treat our patients. If diagnostic and treatment delay more than 6 months, it contributes to peripheral joint erosions and poor functional outcomes. When PSA is identified early, initiation of treatment with targeted therapies can significantly improve the signs and symptoms of PSA and prevent radiologic progression. That is so important because our patients are in the most young. So we, dermatologists, we are the sentinels. Every patient with psoriasis could have or develop PSA. And the PSA had 3 types of involvement: peripheral joints, enthesis, and axial disease. So in my clinic, in my day, I always do these 3 questions for my patients. Do you have pain or discomfort in your spine at night? Or do you have a stiff spine to get out of the bed in the morning? Do you have pain in the soles of your feet? Do you have pain in or around any of your joints? If my patient said yes to one of these questions, I think that I need to be aware about joint inflammation and talk with rheumatology or change the treatment if it's necessarily. So thank you so much.
Any comments on our case, or Neil, as our incumbent rheumatologist, would you like to make a comment?
Thank you, Jaquelini, for a lovely presentation. I guess the first thing is it's not surprising that your patient developed arthritis because it had a number of risk factors: severe psoriasis, nail disease, looked a little bit overweight,
Yes.
possibly. And a red eye, presumably uveitis. So odds stacked in favour of developing psoriatic arthritis. So that's interesting. Possibly what was on ustekinumab but developed arthritis, and the question there is whether biologics prevent development of arthritis, and I think the jury is still out on that one. And then in terms of options for treating arthritis, when you've got the psoriasis well controlled, I think another, maybe not in this case, but remember joint injections, you know, in terms of if there are just a few joints involved and the psoriasis is well under control, and it depends obviously on the severity, but joint injections are still, you know, very useful in terms of rheumatological intervention. But in your case, I think they also had sacroiliitis and
Yes.
a very, very high CRP. That's really quite a high.
Yes, yes.
You'd wonder whether something else might be going on there as well. But so you switched to adalimumab, which is reasonable, and then finally to an IL-23. The patient also had sacroiliitis, and so there it's a little bit challenging because the effective options for spondylitis are normally a TNF inhibitor or IL-17. But the proof is in the pudding, and if a patient is well on the combination that you've got, then that's great. So well done, and thanks for an interesting case.
Thank you.